So I wanted to introduce a very amazing group of guests tonight who decided to come join us. I really appreciate having Claudia, Lena, and Zakia here. So Claudia Rodriguez and Lena are both psychiatrists at the Brigham. Claudia is director of the Outpatient Addiction Recovery Program at the Faulkner, and Lena is the chief of the Division of Women's Mental Health. And Zakia, who I've gotten to know very well recently over the past few, I don't know, weeks, months now, doing a lot of work with Zakia on issues of food access in Dorchester and the Blue Hill corridor. And Zakia is a longtime Boston resident and community activist.
The rest of the potatoes on here.
And has been working as a recovery coach now for a number of years now. And to help others in the community on the path towards health and wellness and recovery. And so, I really appreciate being able to host these conversations where we have both experts from the medical field, but experts also from the community, because that's sort of what we're trying to do here, is bridge the gap between the two. And I welcome, so just some ground rules is that I do ask people to stay on mute if possible during most of the conversation, just to avoid background noise, but would love for people to chime in with questions. And one thing you could do is chat me a question, and then I can sort of call you out and have you ask your question, because it's more effective coming from you than from me. And I obviously have we have a lot to talk about and have questions here on my own too. So, feel free to engage with me through the chat as much as you want to. So I was hoping that we could start just by learning a little bit about sort of broader overview of substance use disorders and understanding, I guess first, maybe defining it from a medical perspective of how we just define substance use disorders with the real emphasis of how is this, do we define this as a medical disease, right? And I think that, you hear words like addiction or substance abuse and so very careful with the term substance use disorder and what that means from like a medical perspective. So maybe, Claudia and Lena, feel free to jump in on that.
Yeah, sure. So Lena, if it's okay, I can jump in and start. So good evening, everybody. Thank you so much for being here. I've been working now in treating substance use disorders. It became really a passion of mine actually pretty early on in my medical career. Just felt like the right fit. And I think, for starters, when we use the term, actually in the communities, we rarely hear the term substance use disorder. That's definitely more of a medical term that we use that coincides with what we consider an addiction. And when I think of an addiction, or, if you guys can think about the last time that you saw somebody who was struggling with that, you see that in it, there is a disease, because it's, it goes back to the very basics of losing control over who you are because of this substance. And so when we think about, there's the 4 C's of addiction, that it's a nice screening tool to help us identify what substance use disorders are. And that's loss of control is a primary one. I think everybody can think about, either a loved one or a patient or somebody that they met that had lost control over their lives because of the substance. Consequences, so right, again, kind of losing family, losing work, losing stability, losing food, not wanting to eat because the drug really takes over. So loss of control, consequences, cravings, of course, is one of the driving forces of addiction. And then finally, compulsive use. And what compulsive use is that a lot of us think that addiction comes because people want to use just because they want to feel good. And the truth is that is how a substance use starts. So the first time somebody drinks, the first time someone smokes cannabis, the first time someone takes a prescription opioid, that time may have felt good. For some people it doesn't, but for some people it just does this, it provides warmth. It does whatever it is that it does at that moment. But once you cross over into, occasional use, to the use that defines addiction, which is the loss of control and everything else that I mentioned, what you're really doing is you're using to take away a negative feeling that comes from not using. And that's where the person is no longer using because they want to, they're using because they need to. That defines the loss of control. And so in the medical community, for us to diagnose a substance use disorder, we use what's called the DSM-5 criteria, which is criteria that's based on a psychiatry book that, you know, we all go for all of our diagnoses, all our mental health diagnoses. But the reality is that what I want you guys to think about in the communities and with the people that you see that struggle is that addiction is really, it's really ingrained in a brain disease model of addiction. When people use drugs regularly, if they don't use it, they simply do not feel normal. They do not feel like themselves. And so recovery is a process that requires some of that kind of brain neurochemistry. It gives it time to recover and do well so that the person, the human behind the addiction, can actually shine through and be who they really want to be. So that's kind of like, you know, how I see addiction in my field and in my work.
Lena, anything you want to add on to that?
No, I mean, that was such a beautiful description and such a clear one. I really underscore so much of what Claudia said. So I don't think I could do anything to add to that.
Thank you.
Right.
Zakia, I'm wondering from you too, like when you talk about addiction to people in the community, you know, it's one thing for a doctor to say this is a disease, right? And for people to say, oh, like, okay, if you say so, but like, what, I mean, do you say that same thing too, or do people sort of get their head around that?
Although I have a certificate for alcohol and addiction counseling, I rarely use what I was taught in the way that I was taught, the way that Claudia just expounded upon for us. It's all true. It's that oftentimes I find myself using the simple language of the 12-step programs, Narcotics Anonymous primarily, that this is a body, mind, and spirit thing we're talking about. And if you're not comfortable with the word spirit, I'll say consciousness. I'll go back and forth between the Smart Recovery Toolbox and Narcotics Anonymous, but it's something that compels people against their will to use drugs. Narcotics Anonymous says in its basic text, how many people would walk up to somebody and say, would you mind giving me a heart attack? No, the idea is crazy on its face, right? But millions of addicts every day are messing with substances that could destroy them or leave them a veritable vegetable. Mm-hmm. And yet they still try to have one more.
Mm-hmm.
Totally. And let's talk about, I mean, there are a lot of factors that go into mm-hmm. maybe sort of tipping someone into the point of using substances and becoming addicted to using a substance. And what are the things that, you know, I guess let's start with just some of the causes or some of the contributing factors that you see day to day, Zakia, in your work. Mm. And then I'll go over to, you know, what we see from the medical side of things.
I don't have any statistics on it, but anecdotally, I will tell you that most people I know or have worked with tell me that they first sought to change how they were feeling. If they were teenagers and they were at a party and somebody said, hey, try this beer, try a joint, try a sniff of this or that, a lot of times it was to be a part of what their peer group or near peers were doing. But other people talk about, they knew they wanted something to change how they were feeling, that they were very stressed out from their living conditions, from school, from some trauma, and they wanted to change how they felt. There's a study that came out of the Boston Public Health Commission about 7 years ago, maybe, about sugar as a gateway drug to addiction. And it's a study on Latina, about 14 years old, I think they were, and how they were becoming close to the edge of type 2 diabetes based on sugar usage that starts early in the morning with a trip to Dunkin' Donuts, where they were reporting 7 and 8 pumps of sweetener in their coffee on their way to school, changing how they feel early in the morning.
Interesting. What about Claudia and Lena? How do you describe it in terms of when you talk to patients about substance use disorder and what may be contributing to this for people?
I mean, I can say for me, my area of expertise is around pregnancy and postpartum. And so, you know, one of the things that I see so often in my work is that women who have substance use disorders and then planfully pursue a pregnancy or unexpectedly find themselves pregnant almost universally want the best that they can for themselves and the potential for the growth of their family. And yet sometimes, despite that immense motivation and the immense commitment to their health and to their well-being to further the health of their pregnancy, it is sometimes really hard to maintain sobriety. And so what I think about then is that is a really, really challenging illness to treat, and that we're in it together. And it's a time of opportunity because the motivation is so high to engage in health related behaviors, but it's also a time of challenge because there's so much challenge in that context of pursuing pregnancy and facing perhaps comorbid mental health issues and a substance use disorder and all of the things that may have contributed, including a pretty common thread of prior trauma, which is often really quite common in the context of the patients that I see. And so all of those challenges that are facing them, plus the stigma and shame and complexity of the situation. And so we have all these challenges, but we also have opportunities because there's the sort of motivation to really move towards health. So I think that's sort of what I end up grappling with a lot with my patients, is that we have challenge and opportunity, and we have to sort of figure out how we navigate that.
Yeah, and to add to what both Sakia and Nina are saying, one of the so there's definitely risk factors that place somebody at a higher risk of developing a substance use disorder in their lifetime. Mental health illnesses, the comorbidity of the co-occurrence of a mental health illness, whether it's depression, anxiety, bipolar disorder, schizophrenia, increases the risk of having a substance use disorder by at least 2 times. And so that's definitely one significant factor. Trauma is undoubtedly a risk factor. And one of the reasons is because if you think about the diagnosis of post-traumatic stress disorder, if others in the audience have heard of this, this is a disorder that we usually relate to our veterans. The veteran comes back from war, you know, they have dreams, they have nightmares, they experience feelings as if that danger was lurking around the corner at all times. But this can happen to victims of assault. This can happen to victims of physical assault, sexual assault. It can happen to people who have witnessed somebody murdered or hurt. And so there's a lot of post-traumatic stress disorder within our community with substance use disorders. And one of the key components of the diagnosis of PTSD is avoidance. And avoiding your memories of trauma is nearly impossible. It's not the same thing as I'm avoiding a dark alley that I'm fearful of walking through, so I just cross the street. I can't get this memory out of my head. So how do people avoid? They use, they drink, and that allows them to disconnect from their past. So trauma is definitely huge. I really appreciate both of you bringing that up. And then there's also adverse childhood experiences that are going to place people at a higher risk. These include if somebody comes from a family that uses substances. I always think of a patient of mine who, when she was in recovery, went to a family hangout, and she was the only person in recovery at that hangout. Yeah. And while she was proud of herself, she felt like the odd one out. She's like, I might as well be using because my family looked at me like I was crazy, right? And so having families that are actively using and being raised in that environment places you at a higher risk. It gives you a familiarity with substances that you otherwise will not have. Experiencing housing insecurities, as Sakia talked about earlier, or we talked about in another setting, but housing insecurities, food insecurities, lots of adverse childhood experiences can actually also increase the risk. So all of those things, I don't like to say it causes an addiction, but it increases the risk of an addiction developing. People with trauma, people with PTSD can also live a life without addiction. So you know, it's not one thing definitely causes the other, but it's definitely increases the risk.
So a lot of environmental and sort of like life experiential factors into this and put people. How much What about genetics? Is there any genetic role for genetics here?
Yeah, absolutely. Absolutely. I forget the percentage, which is bizarre. I should know this, but Lena, do you guys remember?
I'm sorry. I was just thinking like, oh, that would have been a good thing to.
Yeah. It's significant. It's significant. And, I always think it's also hard, like to take out the nature from the nurture. It's difficult. I always think of my patients when I give any talks, but I was just recently talking to one of my patients who struggles with alcohol use disorder. And he tells me that his first drink was when he was 6 years old, because he would make his dad the martinis for him. And so you think of a 6-year-old in that environment, like, of course, genetics plays a role in his story. His father had alcohol use disorder.
Right.
But then he also has this very early young exposure and this familiarity with it's okay to be intoxicated. And that's what we do in this family. And so I think it's hard to tease out, but 100% genetics plays a role as well.
All right, I just want to throw that in there, but I want to move on and talk about stigma a bit now, because I think that that's such an important topic, and it's a big reason why people don't seek care. It's a big reason why people don't get the care that they need, even from the healthcare system itself. And so let's just start talking about how stigma around substance use disorder interferes with people's maybe willingness to seek or even in access treatment. Zakia, maybe talking from your perspective first.
Well, the first thing that came to mind was when Lena was talking about working with pregnant and parenting mothers. The stigma that is attached to a mother who cannot stop using cannot be underestimated. There is so much stigma around it. And so it is an issue that cries out for a community response, a nurturing response that says, we love you anyway. Because the antidote to addiction in a lot of ways must involve building community. People have a hard time recovering in isolation. So if they knew that there's billboards, some kind of campaign in the community, as well as a welcoming door, at a local faith community, the social service organizations that says, you know what, we want to help you. Judgment-free zone, we want to help you. Because that's not what they're hearing most of the time until they get to Lena or Claudia, or perhaps you, Rich, they're not hearing.
But I also think that, being clear that Lena and Claudia are somewhat unique, right, in terms of being as healthcare professionals. And I think there's also stigma within the healthcare system around such. And so I wanted, Claudia and Lena obviously to touch on that as well and talk about from within sort of the medical system, what are the barriers there? Yeah, go for it.
Yeah, I mean, one of the things that's so challenging, I would say, is even in our training, I'm not sure that we learn we don't learn a lot of stories of hope and optimism in our training around substance use. And for me, it was not until I started psychiatry residency where I even had the opportunity or the privilege to really see some of that. So I think that there's a sense of kind of all of the challenges, the medical impact of substance use that we learn about from day one in medical school, but then we don't necessarily learn all the forms of treatment and the ways treatment can work and what recovery looks like and how recovery is a process. And I think that is a big challenge in the healthcare system. And I think that, when healthcare providers don't know and they feel helpless, they tend to sort of just avoid not addressing it, because that's where we want to be sort of helpful and do what we can. And so I think that there's a lot of avoidance of really leaning into substance use in healthcare.
Claudia, I just speak up for a second? I can't let it go said any longer that this is Black History Month, that women could not go to treatment with or without their children or during pregnancy until the 70s. And the first program that we know of in the country where that took place was in Roxbury. It was called Women Inc. Its founder just passed away this summer, Katie Portis, one of the founders. And it was a place where women and children were welcome to come in and recover as a family. Boston also has been on the cutting edge with programs coming out of our Boston Public Health Commission. How many programs do we know? We can name, the three of us probably can name off the top of our head. I'm having trouble with it.
Oh, we're gonna talk about that because I want. Don't worry. We're gonna come back to innovative treatment models and obviously what's happening here in Boston. But I think
I jumped the gun.
That's all right.
It's a very important and a good point.
Don't you worry.
Go ahead,
Claudia.
I wanted to mention, it kind of piggyback on what you guys were just talking about with regards to the stigma within the communities and also within providers. The significant difference, so there's been studies that have shown the differences in Black and Latino populations receiving things such as buprenorphine for treatment. And some of that is because of the lack of access on treatment, and we'll get to that in a second, but some of it is also coming from their communities. So communities have different thoughts about what it means to be on a medication to help you recover from an addiction. And depending on what your community, what your family, what your unit, what the people that you're trying to, prove that you can do well, think, that's going to impact how you seek treatment. And everybody's path to recovery is different. And so it's tricky when you have only one path that is accepted within a community and when the other paths are not accepted. And so I think that that's one thing that plays a role in how people seek and what type of treatment they obtain. From a provider standpoint, to Lena's point, in medical school, we didn't get a lot of training about this. We didn't get a lot of training about, how to prescribe opioids. And so what's exciting is that, and I don't know, Lena, if you've seen this too, I think the medical students and the residents that are growing up in this generation are actually really excited about treating addiction. They're really excited about understanding it. I think they've seen enough people who have been in recovery to understand that there's hope in it. But there's still a lot of work to do. And I want to highlight a study that was done actually in Massachusetts of emergency department, family medicine, psychiatry, OB-GYN, and I think I named all the doctors. Those type of physicians, they did a survey to kind of assess attitudes and beliefs about opioid use disorder specifically. And one of the statistics that stands out is that in that survey, almost 50%, so almost half of the providers surveyed, said that they did not think opioid use disorder was a treatable disease. So they did not believe opioid use disorder was a treatable disease. If you don't think something is treatable, there's no benefit in trying. So, when I saw that statistic, as somebody that treats opioid disorder on a day-to-day basis and gets to see recovery thanks to the treatment that we have, I almost fell out of my chair. But it speaks to the stigma that very strongly exists within the medical community yet still.
Totally. And I want to touch on just sort of how I think those are really important points. And I think it's really important for the audience here to sort of understand what I think a lot of what we do in these conversations is try to sort of break down the walls into the healthcare system and sort of give people a window into sort of how the system works and the way doctors think and all that type of stuff. And I'm just wondering, like, how does maybe stigma and the healthcare profession influence like the approaches to treatment for people? Because I think that like there's I've been reading a bit about sort of the different approaches around abstinence, right? And a lot of the barriers that people face. Like a lot of people, even when I was a resident, people didn't want to go to inpatient rehab sometimes because it was like forced abstinence, right? People were not up for that. And then versus like more of like a harm reduction or contingency management type of model. And I was hoping maybe Claudia, if you wanted to just sort of maybe describe like what the difference between the two, and maybe we can talk about the differences.
Yeah, sure. So an abstinence-based model is kind of like the idea that it's either no use or like it's very black and white, right? Like the goal is always to stop using. Harm reduction is based on the idea that people's pathways may vary, and recovery for some people, they start their journey of recovery and they don't look back. For others, it's a rocky beginning. For others, it's rocky for a long time until they finally get the hang of it. And during the time that it's rocky, harm reduction is based on this idea of like, how can we make sure that this person, even if they are drinking or using, for example, they're not drinking and driving, right? That's protecting them and protecting others on the street. That if they're injecting opioids, that they are cleaning the site before they inject the needle, that they understand how to not share needles, that they understand that there's needle exchange programs that exist, hepatitis treatment. So how do we empower people despite, you know, them still struggling with the ambivalence of leaving a substance to still continue to be safe? And, you know, harm reduction doesn't mean the goal is never to stop using. It just means that so long as they are, you want to kind of protect them and be safe. Of course, that also includes overdose prevention. And so the two ways of thinking are separate, but you know, for it, and it's all about what the patient wants to obtain. And I think change happens when someone realizes that they're no longer living how they want to live. And so that's where, you know, any type of recovery work helps. From a provider standpoint, we've learned more and more that thinking that it's very black and white, all or none, discharging patients for a relapse is not the right way to go, because that's not how people get better. You learn from when you fall. And one of my favorite quotes that I tell my patients is, sometimes you fall because there was something down there that you need to pick up. And so you can learn from those falls and get better. I know, I love that quote.
That's a great quote. That's really good.
So
yeah. No, so I think that's really, because I mean, again, like I am biased by what I've seen, and I've seen a lot of patients who you discharge from the ED and you don't give them any sort of support, or you just say like it's inpatient rehab with abstinence or nothing for you, right? And so is that because like there's less support for harm reduction models? There's less places for people to go for those types of supports. And I don't know if Zaki, you have insights from models that you've seen in the community, or Lena, if you have other thoughts on this. But I'm just trying to understand like why the difference, if one may work better than the other.
I mean, I can certainly say, from my perspective, in terms of, thinking about, so I work as part of what I do as the associate medical director for this program called MCPAP for Moms. And what MCPAP for Moms is a psychiatric access program. And the whole notion of sort of having an access program to help connect people to mental health care is that handing someone a list of phone numbers when they're in the middle of a crisis is such not an effective way to connect to care. And it's what we do all the time in so many settings. And so what really helps and what really helps connect people is really this kind of hand holding, the warm handoff, doing it alongside. So that's why people like Zakia can be so helpful, because if you as a coach are seeing yourself as somebody who can actually help facilitate rather than just hand a set of phone numbers and say, good luck, see you next time, the difference is so palpable, and I think that for me is a big part of why the approach from the health system traditionally hasn't always worked, and especially the emergency room, where it's sort of like there's kind of this like, are you in or are you out? Are you going to stay in the hospital, or are you going to be discharged with some kind of resources? And there has to be something kind of in the middle, some kind of like navigation, some kind of hand holding, some kind of warm handoff to help facilitate those connections really being made.
I find that people need a number of choices, because 12-step programs aren't going to work for everybody. Everybody is not ready to become totally abstinent overnight. And if it's a person who's got a history of relapse, it can be damned uncomfortable to sit next to somebody who's, I got 30 years today, over and over and over again. And we don't have enough places in our community pre-COVID for the person who's not quite ready to make that 12-step commitment, or feels like the 12-step programs are off-putting because the person hasn't been able to string together more than 2 or 3 days clean in a long time, right? So churches, 30 years ago, I could name on 10 fingers the number of churches in Roxbury alone that had some kind of substance abuse support group. And they were all started by ministers or members who themselves were in recovery. And they were in 12-step based recovery, but they wanted to do something in their church to welcome the person who was struggling in a 12-step group or didn't feel comfortable with 12 steps. They wanted to do something faith-based, or maybe they wanted to do something secular, but they felt safe in a church. Well, guess what, y'all? We've lost a lot of our churches due to gentrification and displacement. People's Baptist, which was the home to a recovery program that took place once a year, but had year-round impact. It was a recovering community version of Martin Luther King's birthday. And it was almost like a pageant. People wrote plays. It just was a beautiful thing. And it took months of selfless service to put together. And their home was right there at People's Baptist. People's Baptist is gone. Ebenezer Baptist was the home of a Narcotics Anonymous Thanksgiving marathon for 35 years, maybe, where addicts all over the state knew if there was one day that they could get a good meal, didn't matter if they had used that day or not, come to Ebenezer Baptist. Narcotics Anonymous folks had use of the church for 24 hours. And you talk about food. Oh my goodness. Food and blankets and clothes, all kinds of stuff that people brought to give to the addict who was struggling. Ebenezer Baptist was sold this summer.
Yeah.
And I could go on and on. This is pre-COVID.
That's why it's so interesting to have you, Zakia, because you also, I mean, in addition to your work as doing what you do for folks who are struggling with addiction, like you have such like the historical context given how long you've been. I mean, you've been around. You've been around for a long time, and you've been active in the community. And so I think that like it's also really interesting to sort of understand the trends that have affected some of these programs, right? And like sort of more community-based programs and why they don't exist anymore. So I thank you for, I welcome all history lessons from you, Zakia. I've already learned a ton. Yeah, of course.
Thank you.
And so let's talk about a little about disparities in substance use disorder. And what do we know? I know we were talking about we had some data that I know you guys had been looking at beforehand, and I know it's hard to get, we don't need concrete numbers or anything like that, but just helping people understand. In a lot of these conversations, we talk about health disparities, right? And they're obviously, this is another topic that has tremendous disparities. And so maybe give people a flavor of like what we mean by disparities and what sort of like the big disparities are.
Do you guys want to start? I guess I can start.
Go for it.
There's so much with regards to disparities, and the historical context of how drugs have been criminalized, I think is a whole area of worth discussion in and of itself. Back in when was the war on drugs? Like in the late 80s, early 90s.
It's still happening. So
right. So exactly. But during those times, when they were really trying to crack down on crack cocaine, so base cocaine versus powder cocaine, the sentences for the possession of either were significantly different despite it being the same drug. And people that were caught with powder cocaine required 100 times the amount of powder cocaine compared to crack cocaine to receive the same sentencing. So that really targeted communities of color. And, we still see that happening today, despite the decriminalization of marijuana and cannabis being used at the same rates amongst Black, Hispanic, and white communities. Black Americans are still getting arrested at a much higher rate for things like possession of cannabis. And so the criminalization of drugs and has had a huge impact. And, in an era when we're thinking so much about systemic racism, I definitely think that that's an area that still needs tons of work. Other disparities with regards to treatment, we see that Black Americans, regardless of what type of insurance they have, are, I think, half less likely following an opioid overdose to receive buprenorphine treatment. And buprenorphine is a medication that's used to treat opioid use disorders. We're not sure, we don't have a good understanding as to why. Again, there might be kind of underlying stigma behind that. And then we also see that our opioid overdose death rates have increased, particularly amongst our non-Hispanic Blacks in our communities. And so, again, that's not because it's only people of color that are using, it's really impacting the Black community to a greater extent than any other community. And so I think that those disparities, there's a lot of data that we still need. And I know Lena has some information about disparities, even just amongst women and during pregnancy and women of color. And so would love to hear about that. But those are just a few that I have off the top of my head.
I think those are important. Lena, I want to hear from you too about some of the, based off the work that you and the population that you work with, but I think the importance of talking about opioids and how much it's been, I think Claudia used the term like whitewashed, is like, this is like a very much like a white person issue, so the opioid epidemic. But really, for people to understand that in terms of like overdose deaths right now, is really the Black community that's being affected the most. And why is, do you have any sense of why that is? And is that just a matter of like they don't have access to treatment, to naloxone, to, I mean, like, what do you know?
I think the data point about not receiving buprenorphine treatment is a significant one. I mean, we know buprenorphine decreases mortality very significantly amongst people who are on treatment. And so that has to play some sort of role. But otherwise, I think, within communities, it's depending also on the, I'm blanking on the word, the like socioeconomic, the social determinants of health. That can also have a huge impact on people being able to receive treatment or even know about treatment, and where clinics are located, or how people are able to obtain treatment. So I think it's probably multifactorial. We know that buprenorphine is also seen much more commonly amongst private insurers and like more used amongst private insurers. I don't think that's the case here. Again, this is not Massachusetts information. It's kind of like all the US, but those are some thoughts. I don't know, Sakia or Lena, do you guys have any other ideas?
I'm sorry that I didn't come prepared tonight with hard numbers, but I can tell you that anecdotally, Boston has more programs than anywhere else in Massachusetts. And we have Black people and brown people, Latinos, in positions at like Boston Medical Center to welcome the suffering addict. And it makes a huge difference, a huge difference. So we have Project Assert, and I say we because it's a Boston Medical Center program, City of Boston, whatever. So we have these programs that are right there in the emergency room at Boston Medical Center. However, and I might have talked to you about this before, Claudia, or this other panel I was on about Sunday about the Black Panthers program in the 60s and 70s was acupuncture based with detox. But what I was gonna say is that we don't have enough beds and we don't have enough treatment programs that are specific to the cultural desires of African Americans or Latinos or Latina in this city. In fact, in the Black community, we have no inpatient treatment programs that are owned and controlled by African Americans, but for DMIC, I would think. DMIC community health centers, detox and long-term, what is now long-term, 9 months, programs. We have lost over 135 beds that used to be African American and Latino centric.
That's a great point, actually, like not having providers that are reflecting of the communities that we're treating, and if not providers, having kind of the culturally competent, consistent, there's also a word for that, sorry, I'm blanking on that too, but like the, kind of like the area. So for example, in the Latino community and in the Black community, spirituality might be a big part of what they bring into treatment. And if the provider is not aware of that, it might be something that they miss out on experiencing with the patient. That's a great point, Sakia.
Lena, what were
Thank
you? I saw you had some thoughts too.
Yeah, I mean, I think that, you know, in the context of the perinatal world, I certainly would say I see, and the research supports much of what Claudia was saying, and that women of color are offered buprenorphine at disparate rates than methadone, for example. So women who are offered treatment. And, you know, we see that in the context of maternal mortality, which is such an important topic, especially in communities of color where there are exorbitantly disparate rates for maternal mortality among Black women and among Latina women, that not addressing and not providing care that directly addresses the risk for mortality can simply widen this gap, just blow it wide open. And so I think we're seeing that in the maternal side as much as we're seeing it outside of pregnancy and postpartum. So I think that it's important, especially given the increasing awareness around Black maternal health and the widening mortality rates. And we are the only developed nation where this is the case, where we have increasing mortality rates.
Wow.
Before we go any further, for the benefit of people who may not know the pharmaceutical names that you're using and the modalities, can we talk about that a little bit? But I don't want to be the one, because I'm losing my train of thought.
No, I was actually going to come to that, because I was going to talk about, I want to talk about treatment options, right? And as I think that, like, you know, obviously we're talking about substance use disorders, which encompasses multiple things. You know, alcohol, opioids are the big ones, but there are other substances as well. But maybe for the purpose of what we've been talking about now, talking a little bit about treatment for opioid use disorder as a place to start, and then, you know, maybe we could talk a little about alcohol as well, and maybe just give a very, you know, again, brief overview and pros and cons, I guess, to the different options. I'm looking to my doctor colleagues.
Sure. So there's 3 FDA approved treatments for opioid use disorder. And they are buprenorphine, methadone, and naltrexone. And so methadone has been around since the 70s. It can only be prescribed through a methadone treatment program, which is the clinics that exist where people have to be dosed daily. And it's a medication that basically works by binding to the same receptor as any other opioid, but it has certain differences in how it binds to the opioid receptor, so that one important thing is that once people get to their right dose, tolerance doesn't develop. So the reason why that matters is people don't have to continue to increase their dose to have the benefit of the medication. 2, it's a once a day medication. So if you can imagine someone that struggles with an addiction, they actually have to get dosed, so to speak, a couple of times a day. That takes them out of that cycle. It breaks them free of having to dose themselves a couple of times a day, and it allows them to live a regular life, even though they still have to go to or take methadone once daily. Thirdly, it does have an impact in that it can block other opioids from binding, and therefore, if someone uses while on a significant dose of methadone, they're less likely to get intoxicated, and it's less likely to achieve that level of euphoria. Buprenorphine is a completely different medication. You can get that from a doctor's office. Doctors do have to have a special training for it. Binds to the same receptor, but activates it differently, so not 100%. And then it helps people feel pretty normal once they're able to stay on the medication consistently. Both of those medications, you do have to taper off if you're ever interested in coming off of them. So they can't be abruptly discontinued. And then the third one
is also just known as Suboxone or Subutex, just the brand names for familiar.
Yes, and both are used in pregnancy. And then naltrexone is the third one, and most often we use Vivitrol, which is the once-a-month injection for the management of opioid use disorder, and that one is an opioid receptor blocker. So it binds and does not activate whatsoever. All 3 of them actually function in the same way as I mentioned with methadone, in that if people use, they don't get the same level of euphoria or highness from it, if you want to call it. But generally, all 3 are the FDA approved treatments for opioid use disorder.
That was very
And then
useful.
alcohol, I don't know if we want to get into alcohol.
Yeah,
We should.
let's because I wanted to focus on opioids and alcohol. I think those are the two big ones to focus on here. Again, like we could talk about a lot of this stuff forever, but Claudia, I know you do also a lot of work with alcohol use disorder. Maybe you can give a brief overview of that.
So so briefly, there's also 3 FDA approved medications for alcohol use disorder. One is the same as opioid use disorder, actually. It's naltrexone. So naltrexone also comes in an oral formulation. For alcohol, you can do either or. By blocking that opioid system, your opioid system is our natural opioids are called endorphins. And so by blocking that system, what happens is when somebody does drink, they don't get the same level, the same effect. And so it actually helps people not drink as much or not return to drinking at all. It can also be beneficial for cravings. The second medication is called acamprosate, otherwise known as Camprol. And that medication helps some of the imbalance that happens between two kind of systems in your brain that that just gets, it's imbalanced when someone drinks alcohol chronically. And so it helps kind of stabilize that imbalance a little bit in your neurochemistry. And then the third is a pretty old medication. It's maybe not, I mean, it's from the like 50s. And that one is called disulfiram, also known as Antabuse. And that's the medication that if people drink while they're taking it, it makes you extremely sick and potentially hospitalized, and it's dangerous in the wrong hands. It's not meant to be used for punishment because we don't learn from just punishment. Otherwise, addiction wouldn't exist, right? Consequences. But it's instead a kind of like, it's something that tips the scale in the direction of not drinking. So if I've been struggling with alcohol use disorder and I want to be in recovery and I'm taking Antabuse, I'm basically committing every day that this pill is going to keep me from drinking, even if I really, really want to, because if I do, I'm going to get sick. And so that's how Antabuse works. It's not, you don't feel anything from it, but if you drink, you'll feel a lot from it.
That was super helpful. Actually helpful for me because I haven't really, I don't prescribe these meds, so but I've learned about them. But I think that the big take homes for me are that like there are actually quite a few options for both opioid use disorder and for alcohol use disorder. It sounds like there's pros and cons to different types of medicines out there. I think the challenge is sometimes not all doctors are prescribing these meds, right? And so that's an issue. And so I was wondering, talk a little bit about sort of the sort of delivery system barriers in terms of like who's prescribing these meds, and then also maybe the financial and like insurance barriers for some of these meds as well, like for treatment. That might be useful that you guys encounter in clinic. I think I know Claudia, you encounter this a lot, and it's frustrating if you can't get people the right meds that you want to give them.
Yes, for sure. Yeah, it's the tricky part is prior authorizations, and that means that as a provider, you have to call the insurance company. And I don't know who on this call has ever called an insurance company, but that's like, I wake up every morning saying, God, please don't make me have to call an insurance company today. And so some of these medications do actually require prior authorizations. It's happened with Suboxone, with Subutex, Lena, right? You have to kind of say patient's pregnant, otherwise they can't get a specific formulation.
Yeah, I mean, a big part of it is also even just navigating and knowing what options are available readily. So we can make whatever recommendation we want, but if it's not close to where the person lives, or if they don't have an opening, or if they aren't comfortable, in my case where I'm seeing people who are pregnant, they aren't comfortable with pregnancy, then it's a non-starter. Plus all of the insurance company barriers. And I too wake with that same fear of please don't make me call it.
I imagine like if you want to put like, methadone, people have to go physically to a place to get methadone like every day, right? And so that's a big barrier. That's a big barrier for a lot of people.
It is. And I hope that someday the delivery of methadone treatment will change. Because, you know, one of the great things to be able to do as a provider is to say to your patient, I'll give you Suboxone for a month with 2 refills. Let's check in again in 3 months. Like if you're doing well in your recovery, that should be good. You know, go away for a month, have a vacation, like enjoy your life, right? With methadone, it's so much harder to do things like that people deserve. If you want to go even to the Cape for the weekend in the summer or for a whole week, if you're on methadone and you don't have enough take homes, you got to figure out, is there a clinic there that can dose me, right? You still got to stand in that line, and you could be next to somebody that's just starting their recovery, and that could be very triggering for someone that's been in recovery for a while. So I think, you know, I think the delivery system definitely needs to be revamped. Takia, I don't know if you have other thoughts too, because I feel like I jumped in.
No, I'm glad you did. I can build off of it. What we see in the Black community, like around New Market Square, that's true. I saw in chat, somebody said, Zakia doesn't want to say methadone mile. Hell no. It's soon to be Miracle Mile, because that's hopeful. But let's talk about the methadone clinics over there. They are not as well managed as the ones in other communities that you don't even know that that's what it is. And so those of us that have eyes to see can see, here's a person in the line, might be one of my clients, and they really want to go get that dose, but all around them are drug deals, people selling hot goods, all kinds of foolishness that they don't need to be exposed to in early recovery. And methadone mile area, or the methadone clinic area, doesn't have like the strongest and a number of resident associations to really go to the city of Boston and say, listen, we have to get this cleaned up. But they do have a strong business association, the New Market Square. And then across the street from there is Pompey Street and a couple others, I think, that have neighborhood associations, which often can drive when the city has to clean something up. And maybe that's something that I can do, is talk to them more about it. But the atmosphere of recovery needs to exist in that damn line too.
Right.
It has to be a place, because otherwise all we hear is anecdotes from people who say, that's a horrible thing to have somebody go over there. It's terrible. And I'm against it, because all they hear is the horror stories, or see with their own eyes, the horror story. They don't see the man or woman or person who's doing very well on methadone or Suboxone and going to work and being a productive member of society again. They don't see that. They see the bad examples.
And I guess a question following up on this is just like, with these medicines, do people have to be on these forever? Like, do you cure substance use disorder, or is it something that you manage with medication for the long term? Because I have had a few questions from people like who may have had issues with substances in the past, but still feel like, even if they've been, you know, clean or been off substances for a long time, still feel sort of like the cravings for substances and you know, so does it go away, or like, what do you guys think about that? I know it's a tough question.
It's actually, it's a super relevant question. And, you know, I've had patients sit and meet with me for the first time after they've been like injecting, you know, fentanyl every day, and say, okay, but how quickly can I get off of Suboxone? So it's actually a very common question that even patients bring into the session themselves. The way that we frame addiction within the medical community, or at least within you know, our medical community, Lena and mine, is that it is a chronic disease, and you want to, it's almost like every time you meet with this person, you're planting, and the first time you plant a seed, and then you water it with that person. The person's relationships are part of how they water their, you know, their system of recovery, how they take care of themselves. And so medications is just one part of it. When you think of recovery, big picture, it's so much more than just being on a medication. It's also how they connect with the community, which Sakia was talking about, how they regain function, do they work, how they take care of their bodies, how they take care of their spirituality, if that's important to them, how they take care of their mental health. So I said this earlier, but everybody's path is different. Have I had patients that I have taken off of buprenorphine? Yes. Do I recommend that to everybody? Absolutely not. Do I pressure anybody? Absolutely not. It's kind of, think about it in the frame of any other chronic disease such as diabetes or heart disease, where the relapse rates for those diseases are actually exactly the same as the relapse rates for addiction. But we see those diseases differently. But you wouldn't take a diabetic off of their insulin despite them trying really hard to eat better and do well, right? Their pancreas is not working, so you keep them on insulin. So I kind of see it in that same way. If someone wants to be on buprenorphine because that's how they've sustained their recovery, and before being on it, they almost overdose and die, then I am all for it. And that is what their path to recovery is going to look like forevermore.
I think that's so important and so powerful. And I think the other side of it that I end up seeing sometimes is when people have sort of, they have external factors that are pushing them towards treatment. And then that is not necessarily the most effective way to get treatment either. And so in the context of parenting, in the context of perhaps DCF being involved and suggesting that recovery treatment looks a certain way with a certain externally defined plan, that is not the best way to engage people in recovery, and often results in sort of a, okay, well, when is this plan? What's the end date for this plan? When can I change my plan? And it's a lot, there's not the same, investment unless somebody is coming up with that path that works for them on their own, or not on their own, but with trusted providers rather than having it externally imposed. And so sometimes in the context of parenting or in the context of pregnancy, people have sort of finite relationships that have kind of an expiration date with a methadone clinic, or they have to be in treatment only for a certain amount of time and then they don't have to be anymore. And so then those externally defined points aren't, they're really very almost arbitrary. And the other point I'll just make on the flip side for methadone, I wanted to add this earlier, is that while as Zakia pointed out, there are challenges to the way it can be implemented. I will also say that some centers can be very patient and family centered. So some methadone clinics, and so certainly there are some that have other supports besides just providing medication. So there may be groups, there can be parenting support, there can be diaper supply, there can be a lactation support room, there can be other medical care that's integrated within those settings. And it doesn't only have to be methadone either. A lot of the treatment centers have both methadone and buprenorphine and potentially even naltrexone. And so that's sort of the flip side to the challenging settings that they can sometimes present. And I think can be, finding the right place where there's other supports available can actually really help facilitate care too.
Let me chime in. There's a question in the chat as to whether a recovery coach is a sponsor or something like that, and also about whether or not recovery coaches are in recovery. All recovery coaches are not in recovery. They don't have to be. It's not a requirement. Most people are going to choose somebody who's a power of example to be their sponsor, someone who's in the same 12-step program they're in. But the other thing I wanted to say is that rarely have I met anybody who lives the life they want to live and is on a drug replacement program. Rarely. I've met one woman who I watched over years taper down from methadone while going to a 12-step meeting where she was treated brutally by many people except her sponsorship family. Now, what's that? Well, she had a sponsor and she had women that she called her sponsee sisters who put this protective circle around her in the meetings. And she came off of methadone. She came off of a very high dose where she was nodding in public all the time. She was over medicated. And unfortunately, doctors, this is what a lot of us see: overly medicated people in our community. If we're going to deal with the stigma, we need to call on for help, like MORE, Mass Organization of Addiction Recovery, who's been good about getting voices of people in recovery, where people will agree to have their faces shown and their names said on public service announcements, and they look like they're living a happy, recovering life. We need something like that with people who are doing well on medically managed addiction treatment. substance use disorder. I forgot what it's really called by professionals. Because otherwise all we have is anecdotes and plenty of examples down Dudley or Nubian Square where we see people not doing so well who claim they just came from the clinic. We've got to be able to tell the other side of that story and to support people so that they can feel comfortable recovering in public, so to speak.
Mm-hmm.
I think one of the things I just wanted to touch on too, and just, very briefly before you move on, because I want to talk about two other topics I want to talk about, but that we don't have the same type of treatments for people who are using for stimulant use, right? And for methamphetamines and cocaine and things like that we don't have sort of the same medical options for people. And I think that I just want to put that out there. I don't know, if any of you want to expand on that, but I think that it's important to voice.
Imagine that you have to start your honest recovery program with a damn lie. Because if you tell the doctor or the admitting people what you're really using, you can't get into a treatment program. So you drink a little alcohol and you tell some other story about some other drug that you use, but really your drug of choice is crack. Or what did you say, Rich? Inhalants, did you say?
No, I said methamphetamines.
Methamphetamines. And now I want to hear from the doctors who can talk about it from that perspective.
Yeah, no, you're right. We don't have good treatments for those diseases. And we just focus, there's contingency management, Rich, you mentioned earlier. Contingency management is a type of treatment where you, how do I explain it? It's kind of it's like a voucher system almost. So for example, say if I was coming to your clinic once a week, and for every urine screen that was negative for amphetamines or cocaine, you gave me a ticket. And at the end of the month, there was a raffle and I won, for example, because I had 4 tickets because I had 4 urine screens that were consistent with my recovery. That's a way to explain contingency management. And that actually has some positives around the use of stimulants, but there aren't much medication treatments. And so we go back to, the very basics of human connection, conversation, value-driven treatment. Why not tell me why you use, but tell me why you want to not use today and tomorrow and the day after.
Yeah, I just think it's an important point to name, and something that we don't have the right medical treatments for yet. And so with that, I want to in our last few minutes wanted to talk a little bit about substance use disorders and COVID, because I think that you can't not talk about that right now. Right. So what do we know about what's happening with sort of substance use disorders and the rates of substance disorder in the pandemic right now? Just broadly speaking, what's come out of any studies that have been done?
Well, I mean, I can certainly say that in the context of sort of the work that I do with women, and especially women who are parenting, especially the early part of the pandemic was incredibly hard, because there were no, all of the external supports that were there to help support parenting and help support recovery were sort of abruptly and immediately pulled away. And so women were parenting, managing their own recovery, serving as teachers, serving as short order cook, all of the things all at the same time. And so we were seeing an increased and also struggling with the sort of either the financial changes or having unemployment, where there was sort of a feast or famine kind of challenge with resources. And so, I was seeing and hearing about in my clinical work and in my sort of networks, more use while parenting, more use while, when previously stable, and then also overdoses and overdose deaths were increasing. And so I think that this is what I saw. We saw increased use in alcohol through the MCPEP for Moms kind of provider consultations that we were doing, and an increase in cannabis use. So that's sort of what we were seeing in women, and especially women who are pregnant, postpartum, and parenting.
Yeah, I one of the, And I think there's a lot more alcohol use, it seems, and I've definitely seen people that have been, and this is not research based. This is just my experience in the program. I've seen people that have been in recovery for many years, patients of mine, in the last couple of months, just really struggling. I've seen a lot of people who were very connected to their AA community, just really missing that personal connection and, you know, the kind of like, hey, let me help you out, you know, welcome. It's just people are starting to, that's really starting to impact recovery, I would say. And one good thing that happened though, very early on during COVID, is that we were allowed to prescribe buprenorphine despite not seeing people in person, which was not something that we would have been able to do before. So we were able to provide treatment to new patients. This was a legislation that was passed pretty early on in the pandemic to make sure that patients who weren't on treatment were able to get on treatment despite not being able to come to physically into a clinic. So that was a positive that came out of this.
Totally. And I think that, I mean, to the point that, you know, isolation is a big factor right now for a lot of people. It's driving, you know, relapse for people. And definitely seen, you know, Zakia, I know we talked about that before, and sort of the challenge with just like people don't want to do virtual Zoom groups all the time, and like there's something missing, right, Zakia? Like maybe you can just, in terms of like the community piece of this.
Imagine that somebody was a down and dirty dope fiend. Sorry for the language, but that's the way people would say it.
I know, I'm like,
they're living out of garbage cans, they're down Dudley, they're shameful for their family. One day they go to treatment and they change slowly over a period of time. They're going to these churches at night and on the weekends. They're going not to church, not to worship, they're going to an AA or an NA meeting. And suddenly they're standing up tall and they're clean looking and they're helpful at home and they're helpful in that community meeting, that NA or AA meeting. And then they start volunteering somewhere else and they get a job or somehow they become helpful in their community. Well, COVID took that away. And there's something that I cannot explain except by telling you in 30 years, this is what I've seen. There is something mystical beyond human understanding about being helpful when you thought that you were at the bottom, the dregs of society. People told you that and you told yourself that. And suddenly you're standing proud and you're the person making coffee at that NA meeting for the newcomer and it's gone. I can't tell you how horrible it's been.
Yeah.
Horrible. And then, as I said to you all when we were prepping for this, I think I talked to you all about this. Yes, you can go to a meeting on Zoom. There are 24-hour meetings. I've been to meetings in Russia, Egypt, India, but I can't go next door and get a hug. And then if I don't have a smartphone, I can't get on Zoom the way that we are looking at each other. I can only make a phone call and listen. And I can't share because nobody can see me raise my hand on a damn phone call. And some people can't learn how to use Zoom on a smartphone from a distance. They're not that kind of learner. They need somebody to be in their presence and risk COVID to break that social distancing rule, to show them this is how you call Zoom up on your phone and get onto that meeting. It's ugly.
Yeah, I appreciate you painting that picture because I think it really makes it, you know, it's vivid for people, right? In terms of rather than just like sharing stats and sort of the story. And I think that's, you know, it's really interesting, I think, to hear that, because I think sometimes as providers, like, sometimes we feel like, oh, this is great in so many ways because like virtual care is opening up access to a lot more patients, right? Like we're able to see people in different settings and at home, and they don't have to come, take all these buses and get to the Brigham, and that's a huge pain in the butt for most people. But I think that when you're talking about conditions that so much of the treatment is sort of this sort of like behavioral or social connection, community is so integral to treatment for people. There's something really missing right now. Yeah, that's a big piece of the treatment that you just can't get right now, right? And that we don't know how to solve for.
No. I'm glad to see that some of the recovery centers are reopening. And now let me hear what the other people have to say. But
I mean, do you guys have any thoughts on that? I mean, I just wanted to, I think it's important to touch on sort of like these pros and cons of sort of this like virtual care world that we're in now, right? And make sure we talk about that.
I mean, I think that it's the tension between opening up access when it was sort of like, this is the best we got, so we have to do what we can. Was that we did that for a while, like, okay, this is the best we can do, let's just kind of manage. And then there were times where I was actually quite impressed with the quality of work that we were able to do virtually, that, starting with somebody brand new and making a connection through a screen, I sort of felt like, wow, we can do this. I can do this. I can meet somebody new. I can find out a little bit more about who they are. They can develop some trust in me. So I was impressed with a lot of the virtual care that we were providing. But I think the thing that kept me up at night thinking about it was, who am I not connecting with? Who isn't coming in, who isn't able to do the walk-in, because this is the moment when they were able to get to, for example, the Bridge Clinic at the Brigham, where we were able to do walk-ins and we were able to sort of meet somebody's need right away. Who isn't gonna have that ability to kind of have the immediate connection made, so then they're gonna not connect with us virtually because it's so complex and convoluted. And then also when there's language barriers, our platforms weren't widely accessible by varying languages. Then on the other hand, I've got parents who have kids, and then the thought of trying to get childcare during COVID and come in was totally prohibitive. And they're like, I'm never coming back in to see you in person again, Dr. Mattel, because this is great. I can have my baby here. I didn't have to put them in a stroller. I didn't have to go here and there and everywhere and figure out a whole day of figuring out how to be out in the world with a baby while I'm just trying to go to one appointment. So it's like, I feel like there's like highs and lows for virtual care. And I feel like there are gaps that we have to fill, but there's also a lot of potential and work that we've been able to do that I'm impressed and surprised by too.
Totally. So, I think that's a good point to, and I think there's a lot of potential with virtual care, and I think we're sort of realizing some of the power of it. We're also sort of realizing some of the drawbacks, and so I think in some of those drawbacks, I think Zakia, that's where you and I talk about the power of community and community-based solutions that sort of help, work in tandem with sort of the clinical work that is being done and sort of like what's happening in the doctor's office. And so, if I had to ask you your big vision for what like community-based solutions for substance use disorder could look like, or should look like, if you could wave your magic wand.
People could get treatment on demand, inpatient and outpatient. Recovery centers would be plentiful, not just 3 or 4 in the whole city of Boston. Residents of Boston or anywhere, interested people would learn how to make non-judgmental connections to people that are struggling in the streets where they can see them, on soon to be Miracle Mile, in Nubian Square and other places. Like, join us Easter Sunday. We're gonna go out and we're gonna feed people again. We'll have our love letters with us to active addicts saying, you want some help? We're here for you. And there are going to be the faces of people on the brochure that are newly in recovery who've said, yeah, you can use my picture with this. Find a way to make non-judgmental outreach to people on a regular basis. Have more activities like this. Ask your something that you belong to, the NAACP, your local resident association, a professional organization. Get in touch with Dr. Rich Joseph and others and ask about putting on panels like this in those areas of your life, and just read as much as you can about this, and just try to help people non-judgmentally. Yeah.
I love that. And I think that, what the last question I wanted to ask was just around, we talk a lot about treatment, obviously, but, prevention strategies, right, for youth and adolescents in particular. And I would love to hear from all three of you about that, just in terms of like, if you had your vision for what sort of the best prevention could look like for youth and adolescents, what would it be? How could we tackle that, both from like within the medical world and the community-based organizations?
I think one of either Claudia or Lena both talked about nurturing. And if we teach children from preconception to birth and beyond that they are enough just as they are wonderful, they are lovable, they are loved, and that the world does revolve around them until they're about 6 or 7 years old, and then things change a little bit. That would go a big way, because of all the people that I've worked with over the last 30 years, whether it was a volunteer capacity or in paid work, rarely have I met somebody who thought they were enough. Rarely have I met somebody who thought that much of themselves, no matter what their external posture might be. And rarely have I met somebody who did not have many adverse childhood incidents, from racism and oppression to things that happened in the family, at school, faith community, the Boy Scouts, whatever. People have suffered a lot.
Mm-hmm.
So
yeah.
I think so much about sort of that notion of adverse childhood experiences, and sort of this analogy that the tree of life was the analogy where sort of there's the roots and the soil from which the tree comes, and that's the context of of racism, of poverty, of community violence, of food insecurity, housing instability, all of those things. That's the soil, and then the air that the tree breathes, so to speak. All of the personal experiences then inform kind of the growth and development of that tree. And so when I think about children and adolescents, I think it's kind of parallel to what you were describing, Zakia, which is sort of like, how do we feed the soil and make the air and the nourishment all happen, concurrently. And so addressing and trying to think about, how do we limit the adverse experiences, and then how do we build resilience around the ones that we can't or haven't yet limited or addressed. And I think that comes from sort of a really multi-layered approach. And I think that schools and other settings other than healthcare and clinical settings are really key to that, and having sort of integrated mental health along with wellness and well-being as part of it.
Yeah,
I was thinking of the mental health piece too. There's some things that are sadly not to our control, and it's the foster care system. We didn't talk about DTF, but the separation of family that we see with addiction struggles. What that means to a child, they don't, how they frame that in their own minds and how that impacts attachment. I mean, all these things that, come not just from addiction, obviously, but from just many, many different areas. And I really like the way that Lena put it, like, how do we, as communities, as teachers, as providers, pay attention to what may be missing, or what may need to be watered, right? What may need to be cultivated. Such as connection. I worry about our youth sometimes when I see teens with their phones, and I look on my phone all the time, but how are we connecting? And since everybody's connecting through social media, are there ways that we can kind of pass them with more positivity? Because social media can be really negative, and can we be more mindful about what information and how we're connecting to our kids, and use the platforms that they're using now rather than kind of say that's not how we connect, and so therefore we're not going to try. And so I think that there's a lot, in addition to just recognizing that mental health starts early, mental health issues start early, PTSD happens very early on, and addiction starts early. And so, you know, just educating parents to be careful if they get prescription opioids, to put them in a lockbox, keep them somewhere safe. You know, don't leave it to the curious. You know, don't leave it in your bathroom sink or anywhere where the curious teenager is going to be like, oh, I wonder what this is, and eat it like a Skittle. Right. So, you know, like all these things, I think, I don't know, I'm word salad, but you know, it's Lena and Julia said it perfectly.
It's great because, you know, it's complicated, right? It's complicated, and it's complicated, and we all have a role to play. And I will, you know, want to thank the three of you for taking the time tonight to try to uncomplicate a very complicated issue, or at least dive into a complicated issue and sort of share your expertise with everybody. Honestly, it's been awesome to have the three of you and bring sort of, you know, different worlds together who all come at this from different perspectives. And so, you know, I just wanted to end by just saying that we shared some resources in the chat with everyone, and thankfully Claudia and Lena and Zakia were kind enough to put together some resources for substance use disorder treatment in the local area. And it's not a comprehensive list by any means, but it's based off of their knowledge and what they know and what they recommend. And so we put that in the chat. And then, you know, we also have just some upcoming forums that I put in some advertisements for through the CCW, the Brigham CCW, and put in the link to the chat. So, you know, encourage people to sign up for our newsletter, keep coming out and educating yourself for these discussions that we have. And it's a pleasure being with all of you tonight. So thank you guys, and go get some rest.
Thank you so much for having me. Thank you, Mariana, behind the scenes, for all you did to make this happen.
Thank you, Zakia.
Thank you, guys.